just a couple of moments. My name is Erica Ihara, and I am a project associate at SAMHSA's Gain Center and Policy Research Associates. And before we start the presentations, I have some housekeeping items to review. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters, please type them into the Q&A pod on the right of your screen throughout the event. We will be holding all of those questions for the end, and we will address as many of your questions as time permits. We will also be conducting some polls, and we do appreciate your participation. So when you see a poll pop up on your screen, if you'd like to reply, we do appreciate hearing from you. This webinar is being recorded, and slides will be disseminated via the Gains listserv following the webinar. And we will also notify you when the recording is posted to SAMHSA's YouTube channel. And finally, a certificate of attendance will be available for download at the end of the webinar. However, please note that this is for personal portfolio use only, and we are not able to offer CEU credits for this event. We have ASL interpretation for today, and in order to view ASL interpretation, go to Layout in the upper right-hand corner of your screen, select Hide Non-Video Participants, and change the layout view to full screen, and finally select View All. And we have two interpreters for today, Michelle Johnson and Marika Larson. We also have live captioning for this event, and in order to view live captioning, please select the Accept button in the Multimedia pod, which is located in the lower right-hand corner of your screen. And the color contrast of the caption pod can be adjusted. We do recommend high contrast for best visibility. And so today we would like to welcome you to part one of the three-part virtual learning community on the future of teleservices. And we hope that you can join us for sessions 2 and 3 later this month, and one session in July. So next, I would like to introduce today's agenda. So coming up next, John Berg from SAMHSA will be giving some introductory remarks, and then we will have the presentations to follow, and finally a discussion session where everyone in the audience is welcome to ask questions of our speakers. So for now, I would like to turn this over to Mr. John Berg, who is Senior Public Health Advisor at the Center for Substance Abuse Treatment at SAMHSA for some opening remarks. John?
Thank you so much, Erica. Welcome to today's Virtual Learning Community, or VLC, The Future of Teleservices and Drug Courts, Part 1. Where are we now? Recent developments and emerging opportunity. We're excited to start this VLC today and appreciate you taking the time to participate. The opioid crisis continues to be a public health crisis with devastating consequences, including increases in opioid misuse and related overdoses. The COVID-19 pandemic has had an unprecedented impact on drug court programs and their ability to serve clients. While an increasing number of treatment drug court programs have begun to incorporate technology and teleservices into programming during the COVID-19 pandemic, implementation barriers are a common occurrence. SAMHSA is interested in promoting policies and practices to lower the risk of overdose for persons with OUD who are or have been in contact with criminal justice systems. We're also very invested in assisting drug courts and other criminal justice-related programs, such as reentry programs, to deliver services more effectively to participants in these programs. Teleservices is a promising practice to positively impact the field by increasing the capacity of the justice system to respond to these two crises. The effective use of teleservices increases access to medication-assisted treatment to reduce opioid relapse and overdose, and assist drug court and reentry programs to develop more efficient service delivery to program participants. Problem-solving courts are using technology to transform the way they operate. Drug courts in particular are embracing technologies like video conferencing, smartphone apps, portable drug testing devices, and many others to deliver treatment services, supervise clients, and train staff. Treatment courts across the country had to quickly adapt to COVID-19 guidance and restrictions, building quickly upon lessons learned from previous implementation efforts. Although much of this workforce continues to operate remotely today, treatment court practitioners are now beginning to contemplate strategic directions for a post-pandemic service model. Part 1 of this 3-part virtual learning community presents a retrospective view of the transition to teleservices from the perspective of treatment court practitioners, a review of the mounting evidence base for teleservices in treatment court settings, and commentary on the potential for advancing best practice standards through the use of teleservices. We will also hear the results of a nationwide survey of treatment courts regarding practice modifications, implementation barriers, effective innovations, and intent to continue use of teleservices. We're excited today to host this VLC with 5 experts in the criminal justice field: the Honorable Dwayne Sloan, Victor Vasquez III, Dr. Michael Chappell, Sheila McCarthy, and Tara Kunkel. I would also like to thank the Gaines Center again and their staff for their work in developing and facilitating this VLC and today's session. So at this time, I will turn it back to Erica.
Thank you, John. And now it is my pleasure to introduce our panelists. Honorable Dwayne Sloan, who is known nationally for his innovative work to address the opioid crisis. He is Circuit Court Judge of the 4th Judicial District in the state of Tennessee and co-founder of his judicial district's Drug Recovery Court. And you can see here, Judge Sloan provides expertise at both the national and regional levels on numerous committees and work groups on topics including substance use, problem-solving courts, and best practices for rural criminal justice systems. Mr. Vasquez, who is director of the Webb County Court at Law DWI program in Webb County, Texas. Prior to becoming director, he was a case manager for the DWI court. He is a lifelong resident of Webb County and is actively engaged in the community through public service and multiple educational leadership activities. Dr. Michael Chappell, who is Assistant Professor of Clinical Psychiatry at the New York State Psychiatric Institute at Columbia University. He leads SAMHSA training and technical assistance initiatives for HHS Region 2, which includes the Addiction Technology Transfer Center and the Opioid Response Network. Ms. Sheila McCarthy, who is Senior Program Manager for the National Technical Assistance at the Center for Court Innovation. She specializes in teleservice initiatives, and prior to her role at the Center for Court Innovation, she worked with New York City Family Courts for over a decade. Ms. Tara Kunkel, who is founder and executive director of Rulo Strategies. She worked previously at the U.S. Department of Justice, Bureau of Justice Assistance as a senior policy advisor and as principal court consultant for the National Center for State Courts. She served as a drug court administrator for 10 years, and she is principal investigator on the teleservices practices within judicially led diversion programs, which is a grant funded under the Justice Community Opioid Innovation Network. And before I turn it over to our panelists, I just would like to, first of all, thank everyone out in the audience who responded to our poll. It looks like the majority of folks are calling in today from urban locations, followed next by rural locations, and then by suburban locations. We also asked folks to indicate their professional affiliations, and we have many people calling in from the judiciary, a number of you calling in from probation and parole, and a few of you calling in from community-based organizations, government, and others. So I'd like to welcome you all. Thank you all for taking time out of your afternoon to join us today. And without any further delays, I am going to turn it over to our first presenter, Judge Sloan.
Thank you, Erica. It's an honor to be with this panel and with this audience. Try to set things up. I noticed the number of people from predominantly rural. Where I live in East Tennessee is a mix of rural and suburban. But if you know, think about If you've ever been to Gatlinburg or the Great Smoky Mountains National Park, that's one of my counties. And our judicial district covers, in my view, though Victor will tell you it's not a large area because he's in Texas, but in Tennessee, my district goes from the North Carolina border to the Kentucky border, and covers a lot of areas. So we're we have a lot of barriers that are common to rural people. But thinking back, pre-COVID, about the barriers that we faced trying to help the people that we try to help, they're common. Transportation barriers, access to treatment providers, much less quality providers. And Tennessee is a non-Medicaid expansion state. So getting services paid for is ever more the challenge in those states like Tennessee. Our indigent population there's a safety net funding that really helps people with just the diagnosis of a mental disorder. However, a co-occurring disorder or a substance use disorder is still very lacking. So kind of thinking about kind of where we were, and I do like I say, a drug recovery court, and then I do a more expansive docket called Tennessee Recovery Oriented Compliance Strategy. And it serves over 350 people in just 2 counties, populations of 55,000 and 22,000. And in thinking about how to meet the needs of this population that oftentimes have to go 100 miles, 200 miles away from our judicial district to be able to, for example, get services from a residential recovery provider that can be paid for, or there's some source of funding. Well, much like drug recovery courts, the 10 Rocks docket requires court appearances, not quite as frequent as drug recovery court, but some of those providers would be operating basically on a shoestring. And so for a couple of years pre-COVID, we had started the process of obtaining equipment and software to be able to do hold court or the court reviews for those people and that were away. And so coincidentally, 2 weeks before the world shut down, we got our equipment, we got our training, and we started this process. A second part of that was because of some of the successes of our 10 Rocks program, that we wanted to use this equipment to be able to provide teaching for people that might want to replicate it. So COVID hits, and one of the greatest challenges with me is not being comfortable using technical equipment. But when COVID hit, then I had to fast forward my learning curve. Even though I was in my mindset, I was already ready. But what we found, and we were all kind of suspicious. So is this going to be as good as 3D? Probably not. Is it going to be a disaster? We don't know. But what we found through and the blessings and silver linings of COVID is that because of the licensing and rules related to providing treatment for the people that we serve, something that's really big here where I live is there might be a provider of prescription such as buprenorphine, Suboxone Subutex, that is in close proximity to the people that we're serving that need that medication. However, they are unethical. Their practice is not an ethical one, and so that's a big challenge. So when the rules were lessened, we have people that can be served from 200 miles away with a quality provider. So we've gotten that access. There's no question that it saved lives, and we are so grateful. Some of the just classic IOP classes that people were not able to drive to because they were located in a more metro area, they're now at least able to participate in the group classes. So kind of by way of whether it's services or recovery supports like the group meetings such as NA. The experience has been very positive. I have commentary from our participants about how they got to participating in a meeting with someone from Nebraska and how cool that was, and to be able to find that right place. So in court, and I think, and I hear this from providers as well, seeing people remotely, I'm able to look more closely into their lives. I can see their children. I see where they're living. I see where they're working. And it gives me an added insight to what's going on with them to hopefully try to help them. That's been one of the greatest values in my mind. Going forward, we're going to continue using in court these services. To start out, where we are is people that are in the beginning phases of drug court or 10 Rocks, they will have to still come live. But as far as the incentives and moving forward after stabilization, then the plan is that we continue to see them remotely. Our probation staff also use the equipment this way. We do more smartphone monitoring. So we've learned a lot of things that really help the population that we serve. That's all I have today. Thank you so much for being with you. And I know, Victor, you're next. Tennessee loves Texas. So thank you all very much.
Thank you very much, Honorable Judge Sloan. And of course, so does Texas love Tennessee. So we'll see you at the Baseball World Series, the College Baseball World Series. Thank you for being here this afternoon. I'm Victor Vasquez III. I'm the DWI Court Director for Webb County Court of Law 2. Here in the state of Texas, we are a judicial center of excellence. Today, we'll be presenting to you Access to Justice, Continued Services with Technology for Drug Courts. So here we are, 15 months into a pandemic. The Webb County Court of Law 2 DWI Court Program identified our top 3 successful operational procedures and tools utilizing teleservices. Here they are: efficiency, technology, an increase in participation, and improved engagement of our court participants. Online court hearings provide continued access to justice using available technology and allow participants to complete their program and continue their rehabilitation and sobriety. Importantly, people participate remotely without having to miss work or ask for time off. That's the belief of Judge Victor Villarreal, who presides over the DWI court here in Webb County. By us being virtual, this has allowed us to continue our services through the last 15 months to ensure that services were not disrupted. Servicing through a pandemic continued since March of 2020. Our court continued with intakes, accepting referrals, and individuals that were assigned to participate within the DWI court were continued. Court proceedings were not halted. We continue to have virtual court proceedings for all our participants. Court staffing and supervision continue to meet frequently on a weekly basis, at times even several times a week, to ensure that we are communicating as a staff. Since it involves several agencies, we're continued virtual staffings and the supervision of our participants as well. The treatment and the ancillary to our participants, which was very important. At the end, we've been able to semi-identify that it has been very productive. The drug testing has continued through these virtual services. We've been able to socially and safely conduct these testing through scheduling, through smart scheduling and through smarter ways of doing these testings. And the most importantly, celebrating our participants upon their completion of their term with the DWI court through the graduation. So very important that we ultimately also celebrate their accomplishment of them being able to graduate from the DWI court program. Services in which we did have to halt during the pandemic were all in-person meetings. Of course, it was unsafe to meet in a closed environment, in a close proximity. So all in-person meetings, whether it be within staff and within participants, was halted. Home visits, to the safety of our participants and the safety of our staff, we decided to still not hold any home visits, but we continue to do those virtually. And jail sanctions, we had to get smarter about this. Of course, in some areas, the jails became hotspots to individuals carrying the COVID-19. So it would be both unsafe for the community and for the jail to be able to refer anyone into a jail sanction. So what we did is we got smarter. We stopped sending our participants over for jail sanctions. And what we ultimately did was doing home arrests, and we were monitoring virtually. So at different times of the day, our staff would be monitoring our individuals virtually. Increased efficiency. Video conference capabilities have provided members of the court and participants the opportunity to connect virtually from anywhere. Participants have connected to office visits or court hearings from home, work, lunch break rooms, public spaces, for many who do not have access to Wi-Fi at home, and even from their hospital beds. To effectively provide services, drug courts collaborate with several agencies. During the pandemic, agencies adopted to different protocols and safety measures. Virtual meetings allowed court staff the flexibility to meet rapidly while working from home. I remember some of us even logging in with our, with our pajamas or with our laid back home outfits, meeting, because we were also used to seeing each other in suits here at the courtroom. While being virtually connected, thereby rarely leaving our desks, we were able to complete work faster, making more effective use of our time on the clock. Losing often without having anywhere to go, losing track of time, we were able to continue meetings up through 6, 7, or 8 p.m. in the evening. We only had to break because we were already getting hungry and it was time for dinner, of course. Technology. Most of us have some form of communication device. Court participants may not. For those who do not have devices, some were not technologically savvy enough to utilize meeting platforms. The internet made it easy to connect. Of course, we always knew this, but the pandemic really showed us to not only use it, but to depend on it. Google Voice, WhatsApp, email, text messaging, and many other apps are available free and only require internet access. Participants were shown how to download and utilize some of these apps to have an open line of communication with their court. Above and beyond, our office assisted court participants with enrollment in food bank assistance, unemployment assistance, and many other needed services using technology. Of course, as the vaccine rollout was coming into fruition, we were also able to share with our participants where is it that they'd be able to go out there and schedule an appointment for the vaccine and really provide them information that was very, very critical, as many of our surrounding areas as well also did a stay-at-home orders or anything like that. We were able to communicate it to our participants effectively. Incentive or sanction. Courts can use technology as an incentive for those complying or to monitor closer those participants to sanction. Technology has now really been used in a way that we could have never thought of before this pandemic. Increased in participation and engagement. The courtroom can be very intimidating. Court participants at times felt safer and were more open when engaging in court proceedings from the comfort of their own space. We saw a different interaction when participants were at their own space rather than in the courtroom. They felt at times that they were able to share a little bit more, knowing that they didn't have that presence of them in the courtroom, that they were not intimidated by the presence in the presence of the courtroom. So that was also very interesting, because not only for the clinical standpoint of it, but also for the case management of it and for the probation side of it, that they really, really were open to sharing a lot. And of course, they had a lot more time to really think of stuff that might have been going on at home at the time. Also, the court attendance increased as transportation was not a concern. Unfortunately, some lost their jobs, which freed up more of their time for them to attend court. Court was able to offer extended hours, taking advantage of flexible staff schedules. Of course, we were always made ourselves available, and of course, court staff, we had nothing else to do rather than continue to work. About 75% of current Webb County Court of Law II DWI court participants have been serviced only virtually. Most have expressed gratitude and support for virtual services. Time will tell whether it has been effective, but signs are suggesting favorable outcomes. Video testimonials provided by court participants during graduations are also encouraged. We get a feel of our participants of how is it that they felt during their time through the program. Now, for most, it's not easy. They often start in a rough patch, but towards the end, they're a little bit more grateful, and they're also a little bit more open to seeing the program and to seeing society in a different way and to take a different approach to their life moving forward, which is very good to hear. Opportunities. Like anything else, of course, funding. No additional funding was available to expand our virtual services. Of course, we were not prepared for the pandemic, but we had to immediately adjust. Our participants are among the most vulnerable residents of the community and lack access to up-to-date technology for remote reporting, especially Wi-Fi. Building rapport. As either court or clinical professionals, through the years, we have built rapport in person through body language, facial expressions, and other forms of direct communication. The dynamic is different in a virtual encounter. It takes preparation and tailored approach to build rapport remotely. Of course, these are some of the challenges that we encountered, but of course, the virtual sense is a little bit different than when you're meeting an individual one-on-one. Testing. Though smarter and rapid testing exists, it is expensive for court and participants. Participants were still asked to physically appear to Community Supervision and Corrections Department, probation, to submit a urine analysis, but was it safe? Of course, alternative methods must be identified. Find certified local clinics willing to lock in a set price for your court to conduct third-party testing. You're on mute. That's the most famous line probably that we'll hear coming out of this pandemic. Technology is evolving, and the logistics of it have been challenging to some individuals. Community outreach. The importance of community involvement continues despite our ongoing fight to return to normalcy. Reach out to organizations or hold monthly informational sessions for the community. It can be done remotely. Take the show on the road while still practicing safety measures, of course. Very important that your court still continues to hold some kind of community outreach, even if it's remotely. Here's my contact information if I may be available for anything or anything that I might do for you. Please feel free to get my email and go ahead and reach out if there's any questions or anything else that I can go ahead and further assist your court with. I was Victor Vasquez III, the Webb County Court of Law II DWI Court Program Director, and I thank you very much for taking your time out of your busy day to hear out on this presentation, and we've got more to come. Now, I'd like to present to you the next presenter, Dr. Michael Chappell, who is a consultant with SAMHSA, and he will now be taking over with his presentation. Thank you very much. Here's Dr. Michael Chappell.
Thank you, Victor. Much appreciated. Hello, everyone. we've heard a little bit from Honorable Judge Sloan, as well as Victor Vasquez from the court perspective. I wanted to take a moment to sort of back up and provide a broader perspective on the role of teleservices, including the evidence base. We've often been reluctant to consider teleservices, and much of that reluctance has to do with doubt around whether or not it's effective in the same way that in-person services are. And so we'll address that a little bit today. In terms of making the case for teleservices, there are several things that I'm going to talk about. We've already heard, and we often hear about how it does increase access to care by reducing many of the traditional barriers to the services that we provide. We know that technology is now widely available and widely relied upon, with caveats, which we'll discuss. We also know that receptivity among patients and clients is high. We do know that teleservices have been demonstrated effective, and I will talk a little bit about that and some of the research that still needs to be done. And in particular, when we think about the work that we do, it is a fact that adoption in substance use disorder treatment field has lagged compared to the other fields in which it has been more widely adopted. But we heard Judge Sloan talk a little bit about some of the silver linings of COVID. And I remember thinking of this, in March of 2020, having spent many years of my career trying to promote the promise of teleservices, and much of that implementation being sort of delayed by the lack of regulatory support and funding and other things, that it became apparent very quickly, within days, that the COVID-19 pandemic is going to push teleservices to the forefront. And, that was a great opportunity in my view. And I'm so glad to see that we're here having these conversations today. And I think we need to ask ourselves, regardless of where we stand around teleservices, should we or could we ever possibly revert back to the way it was before? I think that would be incredibly complicated, perhaps more complicated than the position that we were in prior to COVID-19 in terms of slower adoption of these services. So this slide will resonate with everyone. There are client barriers and there are provider barriers to treatment. Clients lack transportation, they have employment conflicts, familial responsibility, limited services local or limited quality services locally. There's stigma associated with involvement in treatment and going into treatment centers. There's insurance limitations and restrictions, and providers alone as well have barriers. They have large client caseloads. There's limited clinical skills for certain evidence-based practices among the existing teams. There are challenges for implementing these practices with fidelity, other limitations around program resources, the difficulty in managing complex cases, clients who have several needs that all of which can't be equally met in a particular service, and again, of course, insurance restrictions. So teleservices has the ability to overcome pretty much all of these barriers that we list here. So first, let's just get it out on the table. Technology is widely accessible and utilized. 81% of adults, according to Pew Research Center, 81% of adults now own a smartphone, 81%. That number was only 35% in 2011. 73% have broadband internet access at home. And so there are caveats to this in terms of when it comes to broadband access, certainly income influences that. Those who make $75,000 or more are at about 92% access. Those that make $30,000 or less are at 56% access. So there are certainly disparities there, which means that not everyone has equal access. But certainly we have widespread access and opportunities, and can outside of our efforts around teleservices, can work on expanding that infrastructure for those that don't have it. But what's clear is that consumers regularly rely on smartphones and web-based tools for health information and tracking. We do this. A lot of people do this routinely. And so it's not far-fetched to think that we would ask them to do the same as a way of accessing our services. So receptivity to teleservices. I mean, there is a wealth of research out there, way too in-depth for me and beyond the scope of this presentation for me to get through all of it, but I can assure you that it's there. Current evidence generally demonstrates that patients use and are interested in using technologies as part of their continuing support. When they're exposed to it, they have a pretty favorable view of it. There's high levels of patient satisfaction amongst many different populations. And that is a very consistently reported finding across the research that we have. I think what we know now, and this may be difficult for some people to hear, is that what it really boils down to is that it's really a matter of reluctant providers predominantly rather than reluctant patients. Providers tend to express more concerns about the potentially adverse effects of things like video conferencing on therapeutic rapport, as an example. Providers often express concerns about the barriers on the part of clients to access telehealth. Does it work? Is it effective? Can you build rapport? Will they like it? Those sorts of things. Will they be engaged? Technology-based interventions range from, many different types of interventions in terms of simple text-based reminders to complex interactive web-based counseling interfaces to smartphones with GPS and biomedical sensors. There are a lot of opportunities out there. They can be synchronous, which means that they're live. They involve live interaction, real-time interaction back and forth between practitioner and client. Or they can be asynchronous, which is sort of like a store forward method where the information can be made available and accessed on demand. So there are a lot of options out there. A lot of what we'll talk about is video conferencing, which is the more widely utilized and accepted approach, especially in terms of what tends to be reimbursable. So in terms of the evidence base for delivering telehealth services via telehealth, I can give you some examples. Like I said, it's incredibly widespread, the evidence that exists out there. There are hundreds and hundreds of articles addressing the efficacy of teleservices in a variety of fields. But here, synchronous teleservices, live teleservices, which are typically in the form of video conferencing, though it can be through telephone, is effective, well-received, and a standard way of practice. And when we say effective, there are many studies out there that suggest that when you compare the delivery of services through telehealth mediums compared to traditional in-person services, that it's just as effective or more effective with regard to a number of outcomes. It's well received by clients and even many practitioners when they are eventually exposed to it. And it's become a more standard way of practice. Recent findings, as an example, from a meta-analysis on video conferencing have some important nuances here in terms of one particular concern about therapeutic rapport. There's been a number of studies that have demonstrated that being physically present in the room with a client does not appear to be a necessary therapeutic component for producing desired treatment effects. So we can establish rapport through video conferencing, just like we conduct meetings and establish rapport with our colleagues in that way. We may have to think about how we intentionally conduct ourselves in that manner, but we can certainly establish rapport through video conferencing. We are still face-to-face. The use of video conferencing alone does not seem to inhibit clients' willingness to participate and engage in services, and in many instances has been shown to enhance that engagement as they find comfort being in their own environment. And to date, there really have been no studies that have identified any patient subgroup that does not benefit from or is harmed by, more importantly, care provided through remote video conferencing. And we also know that telehealth is not more expensive than in-person service delivery and is actually more cost-effective in the majority of studies reviewed. So these are some general findings to really think about when you're considering the use of teleservices and if you're questioning their efficacy. This systematic review of video conferencing found an increased ease of use, improved outcomes around communication, improved outcomes around medication adherence, and then efficiencies in terms of reductions in missed appointments, wait times, readmissions, patient travel time. We can all imagine and probably have experienced through our practice some of those particular efficiencies. Despite this increasingly widespread of adoption in healthcare services in general, so we've seen it in the medical field, particularly in psychiatry, the adoption of technologies in the SUD treatment field has been much slower. And that's something that we have to think about in our practices. And a lot of that can be attributed to more limited user acceptance that has affected both patient and clinician willingness to abandon more traditional practices in favor of new technologies. I think what we have to say is it's always hard to think about doing something differently than the way that we've always done it. We're comfortable with what we do, and change can be a real challenge. But the reality is that if we can get by those, some of those perceptions that we can learn lessons in terms of the value of these new approaches. What we've seen historically in the substance use field is that there has been a higher level of interest expressed in using different types of teleservices or telehealth interventions, but that has not led to adoption. So we see low utilization, and there are some examples on this slide. So the green figures represent the percent that express interest, and the red percentages are the actual adoption or utilization of these services. So you see great disparities there in terms of the difference between those who are interested, but those who actually translate that interest into, pursuing the adoption and implementation of these teleservices interventions. In terms of teleservices for court proceedings in particular, this is not new. You heard Judge Sloan talk about some of the work that was being done in Tennessee prior to COVID-19, while many of us as practitioners, whether we're in problem-solving courts, we're in treatment provider agencies, we were undoubtedly thrust pretty much overnight into a teleservice model. But there has been a history of this in treatment courts and problem-solving courts, and these are a couple of publications from the Center for Court Innovation. A lot of work is being done across the country, even through SAMHSA and the Gaines Center in the virtual learning community. We started last year on a quest around teleservices prior to COVID-19. Again, COVID-19 has been an accelerant for this. Many of us now have experience that we wouldn't have had otherwise, but this is not new. These efforts have been underway for a long time. In terms of the implementation of teleservices in treatment court, in our problem-solving courts, we're looking at teleservices for the delivery of treatment. So these are evidence-based treatment and supportive services, screening, assessment, diagnosis, actual evidence-based treatment practices, and continuing care. There are examples here of client supervision and monitoring that have been accomplished through teleservice mediums, and we'll hear a little bit more about that as we go on. And we can also use it for staff training and professional development. In terms of the evidence base for teleservices in treatment courts, that's sort of the translation we're looking to make now. What we do know is that numerous evaluations have demonstrated the effectiveness of treatment courts in general, not specific to their use of teleservices, in reducing recidivism and relapse. It's a very promising model. Many of us on here know that. It is important to note that the use of teleservices in treatment courts, although it's not new, there has been limited inquiry regarding the specific impact of teleservices as they've been implemented in treatment court settings. Certainly more so in terms of how they've been used to link clients to treatment, less so in many of the emergent practices around the use of teleservices for treatment, for court proceedings. However, I think we should consider the strong foundation that exists right now, and we can build upon that. One aspect of that, evidence-based for the use of teleservices to deliver SUD treatment, should translate very well for treatment court clients receiving remote care. This is what courts engage with these treatment providers in the community who have been doing this for some time. We also have to consider practice-based evidence. We often talk about evidence-based practices and what does that mean, but practice-based evidence, those of us who have been doing it in court, absent maybe some of the clinical trials and other types of research studies that often, lend a quantitative input on the efficacy of these approaches, our practice-based evidence, especially during the pandemic regarding the use of teleservices, suggests that these approaches are feasible and they've had an impact. Now, hopefully in the coming years, site-specific evaluations assessing the specific impact of teleservices on processing outcome measures will increase the understanding of utility, but I think we're in a position to lean on some of the lessons we have learned in practice to continue these services and expand that evidence base. So when the pandemic came, we know we rapidly transitioned to teleservices overnight, so that we could ensure that there were limited interruptions for court proceedings. Regulatory changes designed to increase treatment access, such as expanded access to remote MAT, increased enforcement discretion for HIPAA, the good faith provision, expanded eligibility for teleservices reimbursement. These things all enabled us to do that, and we're still waiting in terms of what that landscape will look like going forward. But I think it's fairly safe to say, like everyone else is thinking, it would be hard to go back. I think policymakers will be thinking carefully about that as well. There were many revised procedures, at state levels enabling remote court proceedings. They will be considering the same things. And ultimately, this is a tremendous opportunity for expansion to capitalize on the momentum that we've gained during the pandemic around teleservices. In summary, my hope is that drug court and treatment professionals should view technology as a powerful partner in improving the quality and productivity of service delivery. It's an ability to enhance access to the services that we provide, and we all very well know that access and those barriers have been a major issue. Not a source of frustration, but really as a clinician or a program extender, a way to plug many of the gaps that exist in the care that we provide. Some resources for you in terms of the citations here. And I'd like to thank everybody for their time today. It's been a pleasure. This is a topic I'm very passionate about and have been working on for many years, and I'm thrilled at the opportunity that we have. At this point, I'd like to hand the mic over to my colleague at the Center for Court Innovation, Sheila McCarthy, who will dive into some of the drug court best practice standards in terms of how they relate to teleservices implementation.
Thanks, Mike. I'm really happy to be here today, and I also am very passionate about teleservices. I've been presenting on this topic for about the last 2.5 years, and it's really pretty amazing to see even what I was talking about in early March 2020 last year for presentations to where we are today. And while there have been so many technology advancements and evolutions during COVID, I think it's also just a really great reminder that virtual everything should not be the norm. And the real purpose of teleservices has been and should continue to be to fill a gap, to use technology to support and enhance, but not to solely replace in-person interactions. So just kind of keep that in mind with regardless of whatever has been happening in the last year. And, we weren't able to make those really thoughtful planning processes because it was just kind of upon us to do so. When you're really thinking about long-term, really try to think about what's worked in the last year, what hasn't, and take some of these lessons learned to improve your court operations and services for participants going forward. And, we're all in different phases right now as far as returning to in-person operations in whatever form that looks like, and redefining what the norms are. So I think it's a good opportunity to just continue to evolve and shift what is known as business as usual. So while we're all familiar with the best practice standards, I'm going to be briefly going through each of them and give some examples on how technology can enhance your current practices and service delivery. And just really quick, for those of you that are not familiar with the Center for Court Innovation, we are a justice reform nonprofit that focuses on reducing crime, aiding victims, strengthening communities, and improving trust in the justice system. And our mission is really to make the justice system both more humane and effective. And that's really the lens that we try to look at in the projects that we're working on. And we do this in 3 main areas. So conducting research, creating operating projects like community courts, and providing expert assistance to justice reformers around the world. That's the team that I'm on, and our team really provides in-depth expert assistance. We do things from helping plan, implement, and evaluate new policies, practices, and technologies, and our assistance really comes in many forms depending on the needs of our clients. We have a plethora of research articles, including some that Mike also had mentioned earlier today. I'd encourage you to check our website, courtinnovation.org, where you can see several different publications that would be useful for your courts. And just a really quick note on language. I know everybody keeps saying teleservices, but I will just say, at least from the center's perspective, we have been using this term for several years, and we really settled upon it because we wanted it to be clear that, yes, we're talking about telehealth and we're talking about telemedicine, but also more. So from the treatment court professionals, we really see this as an umbrella term for these 3 separate ideas. So just kind of keep that in mind when you're thinking about, what exactly is teleservices and kind of the categories that might be applicable for your courts and communities. So let's start with standard 1, target population. Often we hear that we know that there's other eligible participants for your courts that are high risk and are high need, but they might be across the county and they lack transportation, or there might not be a treatment court in that part of the jurisdiction. So are you able to potentially be a hub court and increase your actual eligible participants that you know are out in the community, but you're just not able to reach right now? And there's a lot of different options for that, as far as potentially having somebody appear remotely from the court that's in that area to the treatment court judge. Teaming up with some of the local nonprofits to help with the transportation, to really make sure that you are getting that target population into your courts. And also, when you're thinking about that, you really want to consider the organizational and the client readiness. I will say I'm also on the June 30th session, and we're really going to be going in depth as far as figuring out doing assessments for both your organization and client readiness, and really walking through creating protocols and guidelines, and all that entails really going through a needs assessment. But just as far as using teleservices in general with your participants, you want to make sure that you're creating screening tools to assess and reassess the appropriateness. Some people are never going to want to do remote treatment or appear remotely for court, and they shouldn't be forced to do so. Right now, we're in a very unique situation, but really thinking going forward, individualizing this for your court and for your participants. You want to make sure that you're screening individuals for their level of comfort, ensuring that they have the appropriate technology. What is their internet situation? What Wi-Fi access do they have? And also, just in general, what are the technology needs and barriers as far as the technology and infrastructure at your courthouse, at your jail, at the treatment provider? Would you be able to potentially do some of these screenings from the jail earlier on? A lot of these different technology enhancements are really meant to hopefully streamline some of this process, so you can get people identified earlier and then engaged in treatment and services as early as possible. Equity and inclusion. We know that treatment courts are supposed to ensure equal opportunity for everyone to participate and succeed, regardless of their race, ethnicity, or gender. And teleservices increases access to care, which in turn reduces health disparities. And so when you're looking at how treatment courts should take affirmative steps to detect and correct disproportionality, keep in mind that, yes, any improvement of access to care that comes with telemedicine, and particularly access to MOUD, should be viewed as positive. However, we really want to ensure that this shift does not exacerbate the racism and structural inequality that already plagues our system. And to this end, participants need safe and secure access to telehealth. If we find that there's an increasing need for telemedicine, we must find a way to care for our most marginalized participants. And this can include a whole different series of things, but it could be, getting prepaid phones, assistance with paying phone bills, assisting with Wi-Fi access and hotspots. A lot of states across the country in the last year were able to partner with nonprofits or tap into state funding or tap into federal funding. There's stuff out a lot of times in the community to help support these things, but people aren't necessarily aware. So really just getting a better idea of what is out there to support your participants. Also, systems of care must be designed with input, involvement, and guidance from the participants that were actually served. A lot of times we might think that we have great ideas, but how does that actually translate to the participants that are using them? So if participants with substance use disorder are not engaging in telemedicine, we must ask them how they prefer to receive care. And that includes improved access to low threshold clinical models, and especially continued provision of harm reduction resources. Roles and responsibilities of the judge. We all know that the treatment court judges greatly influence participant success in the program. We know that positive impact when the judge is informed, approachable, fair, respectful. And so how does that translate virtually? One of the things that you want to make sure is that you have consent. I know that in the last year, a lot of these regs have been laxed and people weren't asked, didn't have the option. It was the only option. But as you're moving forward, think about making sure, the individual, for instance, for court appearances, that conversation is being had with their attorney, with their case manager, anybody else that's working in the court, to have them fully explain and understand what it means to be virtually appearing for court. And also, I can say in New York, for teleservices initiatives that we were working on, way before COVID, at the start of every court appearance, the judge had a script and would ask a few questions prior to all the appearances starting. It took about a minute, but again, it's making sure that person is comfortable, making sure that they can see the people on the screen, making sure that they've had that access to their attorney prior to the court appearance, and what happens if they lose a connection. These are things that you may want to make sure that the judge is asking and ensuring at the start of each court appearance. It's of course a lot harder to be engaged virtually. I'll say, for me, it's really hard to be engaged virtually right now. If I was in the room with all of you, I could get a feel for the room and really make eye contact and things like that. And so even when you're able to see the individual on camera, you want to make sure that you're not multitasking, that you're staying focused on the participant, addressing them the same way that you would if they were standing in front of you, using those positive reinforcement, and just really being attentive as possible so that they do feel that connection with the judge. Again, if there's any legal and privacy issues, if there's a situation where you want to make sure the person is in a confidential space and they have everything that they need, Teleservices should be able to facilitate more opportunities for the judge to connect with clients. Also, I know that Judge Sloan mentioned more insight to their lives by seeing their family and kids. So it's sometimes just a different check-in on that. And also just increase access to individuals in residential treatment. We know that a lot of times individuals aren't produced for court when they're in residential settings. So this is another opportunity to have those court appearances and make that connection from the beginning. Incentive, sanctions, and therapeutic adjustments. This is a publication I'd really encourage you to check. It came out last fall. It's on treatment courts in COVID-19. And we did a national survey. We were also meeting with the statewide coordinators monthly to see what was happening in their courts as far as incentives and sanctions. And one of the main themes that emerged across the board was reimagining incentives and sanctions. Several people reported that the lack of traditional sanctions really forced the judges, treatment staff, case managers, and probation officers to explore new ways to engage and motivate participants without immediately resorting to sanctions. Numerous programs reported that participants were more forthcoming about their use when they knew that jail would not be imposed as a sanction, even when the drug testing was not happening to monitor the compliance. And I think that really demonstrates the value of that therapeutic alliance. It can be a great opportunity to incentivize and reward. It can be used as a reward for phase advancement. If someone's further along in the program, does somebody have a job? Instead of losing a day of work, they might be able to go out to their car and appear remotely for court. You really want to think of it as a hybrid model. Substance use disorder treatment. So using technology for screening, assessment, diagnosis, treatment. Are you losing people from when they leave your court before they get to the treatment provider for an assessment? Can you have more of a warm handoff, or when they're in the court, they're actually in a room and doing a video assessment with the treatment provider? This might ease some of the anxiety and other issues of who am I going to see when I get there? What does the program look like? Get some of that. Also, just to streamline the process. We know often it can be a long wait to get somebody an appointment for an assessment. Can you have an MOU between the court and the treatment provider to have certain days where you think you're going to have more assessments, and they can just do it on the spot? If you have individuals that are in jail, can they be assessed for treatment court remotely? We have some courts that we work with, they've been doing this for the last couple of years, so the court coordinator doesn't have to miss an entire day of work and being outside of the courthouse because they're at the jail waiting for people to be produced and all those other things. If that happens when they're at their desk in the courthouse, they can continue to do the million things that are also on their plate. It also expands the arsenal of available services and specialties. You might have a great practitioner with a specialization, but they're too far to access. Of course, one of the biggest game changers has been the remote access to MOUD, which a couple people have already talked about, which is great, as well as some of the evidence-based interventions that Mike made mention to. CBT for CBT has been around for several years. There's also been clinical research done on it. So there are a lot of options out there. They just have been underutilized. And I think another way, just as far as from case management or clinical check-ins, You know, do you have evidence-based interventions that you can use to really structure those conversations more, whether that's interactive journaling, MRT, just to name a few. Complementary treatment and social services, again, like treatment plans and looking at the continuum of care, you really want to individualize the teleservices options based on the participant. You know, can you have potentially some interventions that might have been happening over the phone? Can you now do those on video? Enhancing recovery supports virtually through recovery apps and online networks. A lot of courts over the last year and a half have created closed groups within apps like In the Rooms, and they found it a great opportunity for participants to really get engaged in a way that they weren't before, to share resources. There's been virtual town halls, which some states have already continued to use, even though they're back in person. The use of virtual recovery support platforms has really opened up new avenues for treatment courts to support participants in a different way than they traditionally have been. Also, a lot of these online meetings and apps provide proof of completion. If they don't have them, take a screenshot, or better yet, ask them to write down something that they learned. Share a new resource. This should be another tool to further engage the conversation. You know, some participants have found online support groups to be a safer place for people feeling more comfortable to share. Others, it's less than ideal. An in-group, you know, person really suits them much more. I think especially for any clients looking for a specific population for a meeting that might not be in their area, this is an additional support so that clients don't feel more isolated. Also, we've heard from some places in really rural communities, they don't want to go to that only one meeting that's offered in their town where they know everybody. So again, if nothing else, I would really suggest that you offer this as an additional option, especially in your aftercare plans. You know, the more tools we provide people with, the more support that they have. And of course, just another connection with peer and alumni. They might not be in the courthouse that day, so could you do some type of video introduction or thing like that? Drug and alcohol testing, so just adjusting drug testing in general. Of course, remote BAC devices fill the gaps of traditional toxicology screens and sweat patches, video supervision and monitoring between probation and participant. Because again, you know, yes, I understand the importance of drug testing, but really you would like the individual to self-disclose and not solely relying on that. And what that means is I think just adapting and redefining our metrics, leveraging our therapeutic instincts, and being really clear and consistent. There's been a lot of ways, especially in the last year, that courts have been able to report virtually and track these measures. That's anything from scheduled phone and video calls, meeting attendance verification, emailing worksheets, weekly reporting summaries, GPS monitoring, contingency management checklists. There's a lot of different options there are available. Multidisciplinary team. The drug court team approach is indispensable. We know that teamwork makes the dream work. A robust, solid, communicative team is really crucial for success. Staffings. Going forward, are you going to allow treatment providers to participate in remote staffing so that they can be more part of the conversation? Often they can't leave because that means time away from participants that they are serving, so keeping that as an option, as well as operational meetings. And also court staff connecting on video with the treatment providers. Just like it's hard for the treatment provider to attend staffings in person, it can be really difficult for a court coordinator to get to the treatment facility. You know, there might have been a big turnover, and having the court coordinator just zoom into that facility to do like a lunch and learn and provide new policies and procedures, have them get a better understanding of whatever your treatment court is. Opportunities to have physicians and nurses more actively involved. We know that's a struggle to get them involved in the treatment court team. So could they do some type of appearances, even if it's once a month, to sit in on your staffing meetings or operational? Just again, another option to fill that gap that might be there now. Census and caseload, of course, technology can help to better manage caseloads. An option is to establish sub-treatment courts, for instance, identifying counties that do not have a treatment court, and then others that are at maximum capacity, and working with them on a referral process to the nearest appropriate treatment court, incorporating protocols to support these creations. Again, you know, just really figuring it out depending on what is happening in your state and what is happening in your local community. And monitoring and evaluation. Adherence to best practices is among the characteristics we know that distinguish drug courts from business as usual. So technology can help to coordinate data collection and analysis, In some places, we know there's no centralized system for data collection. Could this be improved? Measuring and evaluating outcomes and effectiveness for teleservices participants. How do you do this? You want to make sure that you have teleservice performance measures. You want to make sure you're providing training and guidance on the input of the new teleservices performance measures into a case management system, however formal or informal that is. Also, training and guidance to use performance measures for program improvement. We know that you can't measure success without data. So really keep this in mind when implementing. I know that was a lot of information. I was trying to talk as fast as possible. I know that we still have quite a bit to cover, but this is my information on here. Feel free to reach out to me. And again, I'll also be at the June 30th session to talk about the assessment process, and I'm happy to answer questions then as well. I am now going to turn it over to Tara Kunkel.
Thank you so much, Sheila. And I'm excited to be wrapping up the formal portion of today's webinar. And I'm going to be presenting to you the results of a national survey that we conducted where we asked treatment courts, and particularly participants in treatment courts, about their experiences with virtual services during the pandemic. This is an amazing complement to the research that Michael presented. This gives you kind of a real-time look of what people had to say. I'm going to move us through a set of slides pretty quickly just to lay the foundation for who we talk to, and then really spend more time on what they had to say. So the survey was conducted primarily in April and May of this year. And as you can see from the slides, we had amazing representation from the entire country. So we are very comfortable that we heard from very diverse voices. Here you can see that primarily we spoke to, or the survey was conducted with people in adult drug courts, DUI courts, veterans treatment courts, and so on. This reflects kind of the census of problem-solving courts nationally. The majority of individuals completing this survey had been in the program for at least a year. So many of them had had previous experiences being in person, and they were comparing that experience to virtual. And 20% were identified as Hispanic. The majority, 75%, were white, 59% were male, and here you can see a very good age distribution. We did not find differences based on gender, race, age, or geographic location in terms of what people had to say. So I want to say that up front. So first, we asked them a set of questions about their experiences with court. At this time, in the spring of 2021, the majority were attending court virtually, although there was some hybrid appearances taking place. And we asked them a series of comparison questions about their experiences being in court virtually and then being in court in person. And in a lot of ways, their experiences did not differ around court. We will see some differences later on in some other settings, but in court, participants reported that they felt like the judge knew them and their case, whether the court was held virtually or in person. That is fantastic news. They also felt very comfortable, regardless of setting, being open and honest with the judge. They felt comfortable participating, and actually there was a slight increase in comfort when they were participating in court sessions virtually versus in person. They found it helpful to watch the judge talk to participants, and that really didn't vary depending on the format that they were participating in. You know, we've spoken on this webinar about our attention span being a little bit less when we're virtual, but they still found it helpful to listen and observe the judge's interaction with other participants, even when they were participating virtually. And then we asked them what they prefer to do in the future. And over half said they wanted to attend court virtually 100% of the time. And for those individuals, their reasons why were they felt safer during the pandemic. They were less anxious. We heard a lot about anxiety in the comment section. So they were allowed to offer some free text. They talked a lot about being less anxious when they were attending virtually, and that they were just more comfortable overall. But there is this mix of people that want to have options. So sometimes they want to be in person, sometimes they want to be virtual, and then a subset that would like to be in person. There are reasons why they liked seeing the judge in person and they felt disconnected when they were virtual. So this gives us a sense that regardless of setting, drug court participants all across the nation are feeling pretty comfortable. happy with virtual services. So next we asked them a set of questions about their treatment experiences. And here we still see in the spring that over half were participating in treatment virtually 100% of the time. And then again, some mix of in-person and virtually. Same format, we asked them to compare their experiences. So there is a slight increase in people feeling like the treatment staff can be helpful when they're participating in person, but not much difference. And still 70% of the respondents said that they felt like the treatment staff were very helpful virtual in terms of helping them address issues they were bringing to the table. In terms of feeling like they can be open and honest in group settings and in group treatment settings, no difference between whether services were delivered virtually or in person. Anxiety. So we do see that anxiety was lowered for people when they were participating in treatment groups virtually versus participating in person. And that was anxiety about talking about their feelings, their experiences. So we do see some improvement or some lowering of anxiety when participants are allowed to choose to participate virtually. In terms of feeling connected, there is a sense of being slightly more connected to other group members when treatment is held in person. So I think this is an area for treatment clinicians to really start thinking a lot about and honing in on how do we build a sense of connection in a virtual environment among among participants. This I think is some areas of future work for sure. People do feel slightly more like their privacy is protected when they are participating in person, but still 62% of the participants did feel like their privacy was protected when treatment groups are held virtually. Again, I think treatment clinicians all over the country are thinking a lot about this particular issue and establishing group rules and protocol that help people feel safe and like their information is protected. In terms of feeling embarrassed to attend groups, there was a diminishment of embarrassment when they were participating virtually. Whether that's about just sort of a sense of privacy when you're online or the being seen in public or in the parking lot of a particular facility, we don't know. We didn't ask a lot about why this is, but we do see again this sense that maybe some people are a little bit more comfortable attending treatment groups virtually because of privacy or embarrassment. So we asked them again their preferences around treatment, and 43% say that they would like to attend treatment 100% virtually in the future. Another big chunk would prefer to be able to choose. And then a small portion really do want to be 100% in person. And this is very similar to their experiences with court. Some portion of people feel more connected when they are in person, and they really like seeing their peers and feel not only a connection to the clinician, but their treatment group members when they're in person. And then others just felt like it was more comfortable, or that some of the barriers like jobs were removed when they were participating virtual. The final area that we explored was their attitudes and thoughts about community supervision, so probation, and what were their experiences. The majority were seeing their probation officer primarily by video or phone versus in person, although a little under half were going to the office and seeing their probation officer at this point. So I think this is an area that really surprised us. So in terms of how helpful the contact was with their probation officer, definitely it was helpful pre-pandemic, but there was a jump in how participants viewed their probation officers, and they were seeing them as slightly more helpful post-pandemic in this sort of virtual environment. Again, we don't know why, but they also, and this was interesting, felt like they could be more open and honest with their probation officer after the pandemic, whether that's virtual setting, whether that's the support the officer was providing, or a change in practice or protocol. Again, we don't know, but this is kind of really interesting feedback. We also asked them what the court staff was doing in terms of contact that was really helpful to them. And here we see that the court staff sending text messages was considered extremely helpful to the participants. I know this was maybe for some people a new practice to be texting with participants. I would say based on our survey results, keep it up. They found that to be helpful. The phone calls also very helpful, and home visits a little less helpful. Again, whether that was about what happened on the home visits or just sort of anxiety about the pandemic, a sense of not wanting people in their space, we don't know. But definitely keep up the text messages and phone calls. We've heard a lot about barriers to access. We've seen national data on it. We asked them about their barriers. And here, you know, surprisingly, the majority did have access to equipment. They did have access to reliable Wi-Fi and internet. Again, we had a good distribution of rural, suburban, urban. We do know that broadband is an issue in some communities, but most felt like they had that. They had the private space to participate in court. They were comfortable using technology. So again, I think this is food for thought. For those where they disagree, certainly I think courts are thinking a lot about purchasing and providing other access points. But here, this is just a reaffirmation that maybe some of the perceived obstacles and barriers aren't as strong as we think. And then finally, we just asked general questions about their experiences during the pandemic. And this is what they had to say. So definitely increased mental health symptoms, especially depression and anxiety, was the single largest experience that participants reported during the pandemic. But like many, they experienced a loss of job and income. There were self-reported relapses in sobriety. Many had lost a close friend or a loved one to either a fatal overdose, or they had someone close to them in their life that had a non-fatal overdose, and then so on from there. And when we asked them about the factors contributing to relapse, because again, I think this is food for thought for drug court teams and treatment court teams in general about what kind of supports people are needed, it was really about stress or boredom or that isolation. So I know clinicians have really modified some of their curriculum and spent a lot more time on these topics, but this is an affirmation of kind of what people have been struggling with during the pandemic. So that is a really quick walkthrough of what we found talking to participants. At this point, this represented about 750 participants. We have had this survey open for an additional month. We now have around 1,200 surveys, so we'll be updating this in a written publication that will be put out with myself and my partners at the National Center for State Courts in Wayne State University. Later in the resource section, you'll see a section on a staff survey that we did. So if you're interested in what staff had to say, a lot of the questions mirror what I just presented, but we were asking the treatment court staff. So please give that a look as well. Thank you.
Thank you, Tara, and thank you to all of our presenters today. I am just going to walk us through a couple of last housekeeping items before I turn it back over to Dr. Chappell to begin the discussion group. We have mentioned that there are a couple of downloads available, including the attendance certificate and some publications. So you should see a file transfer box pop up on your screen in the next couple of moments, and you can go ahead and select any or all of the documents that you'd like to download. Go ahead and select them with your mouse and click download. Once you've done that, the process should just automatically start to download them to your computer. Some of you have been entering your questions to the presenters during the webinar. Thank you for doing that. If you have questions you'd still like to ask, please continue to type those into the Q&A pod. And again, we will cover as many of those as we are able in the time that is remaining. And I'd like to just share some information about upcoming webinars. Next slide, please. And next slide. One more. Thank you. And here are some upcoming webinars, including parts 2 and 3 of this virtual learning community. If you are subscribed to the Gaines listserv, you will receive announcements, including the registration links for all of these events. Next slide, please. If you are not already subscribed, here is the place that you can subscribe to receive all announcements from SAMHSA's Gaines Center. I encourage you to register if you'd like to receive those announcements. And finally, here is our contact information at SAMHSA and at the Gaines Center. If you have additional questions for us, please do not hesitate to reach out anytime, either at the website or by phone, and we would be happy to speak with you. So for those of you who would like to stay on the line, we will be moving over now to the discussion with the panelists. And so I will turn it over to Dr. Chappell to lead the discussion. Thank you.
Thank you, Erica. And I want to especially thank our many presenters. This was an incredibly informative session, and I'm glad to see so many folks are here for the discussion section. We do have a couple of questions in the Q&A, and then there were also some questions that were submitted in advance, which I will, try to pick and choose from in terms of, in terms of priority and kind of work from there. I do want to start a little bit since the last presentation we heard from Tara about the survey results folds nicely into some of the research that I had presented earlier. And I want to first clarify there was a question about a copy of the survey and results, and those were just made available through the file transfer link, and we can make sure that everyone gets those. I did want to clarify that the publication that was provided in that link presents results from staff, from Problem Solving Court staff, and many of those same questions, and that the participant results that Tara presented are not in that particular publication. She had just mentioned that they're still continuing that survey. They have up to 1,200 participants, and they would be publishing those results. But given, Tara, I wanted to ask you if I could put you on the spot, given some of the research I presented that suggests that providers are often reluctant to teleservices. They often have perceptions that clients are reluctant to teleservices, but your data clearly suggests that they may not be. And actually, if you review the publication that we did circulate around, you will see a fair amount of reluctance among providers in some cases around teleservices. I was wondering if you could kind of comment about the discrepancy, if you will, and what some of your observations are there.
Yeah, so I'm a former drug court administrator, so it's easy for me to think about what might be going on. We all remember the exceptions to the rule. As a drug court team, we think about the one case where something extreme happened, including inability to have access. But I think the results are really clear. The staff think that the participants have more barriers than the participants report. That's really probably one of the biggest takeaways from our work to date. And so I think we have to remember as drug court practitioners that there are going to be cases that are the exception, and it's important, and we've learned how to be flexible during the pandemic, but to not make big policy or practice decisions based on the outliers, but to be flexible and to create different pathways is probably where we need to be headed as a field. And I certainly think with the grant funds that are out and the opportunities that have been presented with some of the emergency stimulus money, we can remove some barriers. You're not going to probably fix broadband, but we can fix some of the other issues. So I think the challenge now is how in practice do we operate hybrid models that are flexible and can be adjusted to every participant, but that we don't focus on the extreme issues. I think for the most part, people are able to serve more people by having these flexible pathways than ever before. Some of the obstacles that made people say no to treatment courts, like jobs that interfered, some of that can be worked around now with these more flexible models. So that's exciting to me as a former practitioner. So that's my rambling thoughts on why is there this discrepancy and what do we do with it?
Great, thank you. Yeah. Did somebody else have a comment, or was I just hearing myself talk? No? Okay. So yeah, so I think that's important. When you take a look at that survey, that was one of the things that struck me, was that there were some pretty large disparities in terms of court practitioners' perspectives of teleservices for the client. I mean, some tremendous disparities where they rated sort of in-person services as preferable and all that sort of stuff. And it really didn't jive so much with the perceptions of clients. And I think that's historically been the case when it comes to the adoption of teleservices, that there's a reluctance on the part of providers, not as much on the part of clients. And I think going back to Sheila's point in her presentation about, this not being a one-size-fits-all model, we're not promoting teleservices only. We're promoting the ability to expand access in certain cases for certain clients to these services, and the hybrid model is going to be that approach. And then we'll talk about this a little bit, because there were certainly questions about how do you make those decisions about who, what, when, where, and how. But I think that's a really important discrepancy to note, because I think it is a major barrier to implementation from the provider side. And of course, we often drive those policies and what we choose to pursue. And it's been that way for a long time. There was also a question, I think this is really important. Is there a standard screening tool for virtual participation? And can you specify or point me to the questions you mentioned the judge asked prior to the beginning of a court session to ensure a participant understands what is meant by virtual participation? I think in terms of the first part of the question, is there a standard screening tool for virtual participation? To my knowledge, the answer is no, in terms of sort of a comprehensive assessment of appropriateness for virtual services. I mean, obviously, and this is something we're actually going to address in a part 2 of our webinar series on June 30th. So definitely, be sure to come back for that. But I will say at this particular point, there are many sort of dimensions to consider when it comes to, assessing for appropriateness of virtual services in a hybrid model. I mean, one of which is obviously technology access. And there are some folks in Montana courts who have developed, teleservices assessments that focus primarily on elements of technology access. But broadly speaking, part of it is also going to have to do with client preference. I think you saw in Tara's survey results that even though overwhelmingly there is support among clients expressed for their continued participation in virtual services, there is also a subset of clients who wants to do treatment in court in person. And I think the reality is that if you have clients that are more comfortable that way, that we have to think about how to accommodate, that need. And so we are going to talk a little bit more about that in the second session, but I certainly would open it to some of my panel members. And there was a second part to that question around trying to scroll through the questions the judge might ask prior to the beginning of a court session to ensure a participant understands what is meant by virtual participation. I think that might have been a comment on Sheila's presentation, but I'm not positive.
Yeah.
Yeah.
So I'm happy to jump in. I think what you just said, yes, we're going to be covering a lot of that at the June 30th session. And really, when you're talking about creating these screening tools, you really want to know, what are you creating the screening tools for? And so, normally but pre-COVID, when we would do teleservices planning and implementation, like it could be easily 6 months of planning, because you really should be doing this to identify the service gaps, not just like, oh, we have this, so we're going to do it. So we will be talking about that, in depth, and then figuring out what makes sense for your court. I will say in New York, for the teleservices initiatives that we did, as far as doing the consent piece, we started that, and depending on what types of appearances you were going to be doing with. So we initially piloted for only individuals that were in residential treatment, because none of those people had any access to the judge face-to-face. They did not have any access to the case manager. And so we wanted to start those things from day one. So when the case manager would be going through the process of, just the rules and responsibilities and expectations for treatment court, also explaining, there would be options to appear remotely for court to see the judge. If there's an intervention, this could potentially be done on video. Really explaining the process to the participants and having that a part of all of their written procedures, just kind of adding it either as an addendum or in just the regular procedures that were in there. Then at the start of the court appearance, the judge went through about 5 questions. Just introducing themselves and initially starting out, making sure that they had an opportunity to speak with their attorney in private prior to the court appearance. And again, when you're creating these guidelines and protocols, you want to have backup for all of these things. If you lose connection, do they have option to speak with the attorney, on the phone? There's a lot of different logistics in that, but having the judge ask, again, do you consent to today's proceedings being conducted by, teleconference, video, whatever the setting is. Making sure that the individual is able to hear and see not just the judge clearly, you really want them to be able to see the main players in the courtroom the same way that they would be if they were in the physical courtroom. You know, are you able to see the prosecutor? Are you able to see the case manager? Let us know if you can't see something clearly. And also really making it clear that this proceeding is not being videotaped or video recorded. It's being recorded by a stenographer. Just really explaining each piece. It takes about a minute, but you just want to make sure that's kind of setting the stage and making sure the person's comfortable before the appearance actually starts. And then just any notices or things like that. But just kind of to lay the groundwork for that, even though it might not be the first time they're doing it, I think it's really important just to reiterate that at the start of each appearance.
Thank you, Sheila. You know, and I think it's also important to note that in the second session, in addition to going over some of these logistics in terms of assessment and preparation, one of the themes or the emphasis on what for one of our speakers will be on sort of the preparation and the potential training needs of staff and clients alike. It's not, even though technology is widespread, even though we have the perception that so many people use it, everybody's locked into their cell phones, you know, we use technology for everything that we do. It isn't necessarily as simple as plug and play all the time. We all know that. Many of us may have had trouble getting into this meeting today. You know, it's not always just buying the license and logging in. There are certain issues around etiquette and preparation for best practices around engagement and many other things that we can use to sort of prep staff and clients alike to more effectively utilize these mediums. I think the difference is that we didn't really have the opportunity to do that in March of 2020. We just did it. And so, you know, the silver lining is that we were able to accelerate the use of teleservices and put us in a position towards more permanent adoption. You know, the caveat or the backlash is just that we didn't necessarily do it the way that we would have liked to do it had we, you know, had this has it evolved more naturally over time. And so I think that's something we're going to have to take a step back and think about is, many of that's may be in place over the last 15 months as we've sort of slowly gotten used to, stabilized everything that happened in the immediate aftermath of COVID and gave some more intentional thought to our practices. But that will be another emphasis of the second session. So if that's something you're interested, you know, certainly tune back in because that will be important. Additional questions. Have we looked at the health of our professionals, including self-care, that are providing these services to the population? I mean, I can certainly say that as a director of several different training and technical assistance initiatives, self-care has been a major emphasis of the training that we provided to providers, you know, treatment providers, court practitioners, et cetera. As you know, this transition has been extremely stressful for everyone. I think this should be a focus of our efforts no matter what, whether we're in person or we're virtual. But certainly in many ways, the efficiencies created by virtual services, and Victor talked a little bit about this, the hours that we've worked and sometimes being at home. This has always been a problem in my career is I can't figure out when the clock stops because I don't have to leave my office and get on the subway. So that clock just seems to keep going, and sooner or later dinner's ready and I have to pull myself away from the computer. And I think in many ways, while we've worked more efficiently, maybe we've gotten more done, we've also seemingly worked a lot harder. And I think Zoom fatigue is something we all sort of know. In this case, I should say, you know, WebEx fatigue as well, or online remote meeting fatigue. But does anybody else on the panel like to comment about sort of the role of self-care and some of those responsibilities?
Yeah, I mean, Mike, you've seen some of my, you know, longer presentations, and I usually spend a significant chunk talking about self-care, just in general, because, you know, I think we always talk about that with our participants, but are you actually talking about that with your staff, and how are you promoting that? And whether that's virtual or in person. I can say that I know that several treatment courts, whether they were mental health courts or drug courts, found really innovative ways to provide some other opportunities for participants in the last year, whether that was partnering with local nonprofits to be able to provide tablets where they could do some type of art therapy, or actually dropping off materials at individuals' homes, and then they could do some activities on Zoom or whatever it was like that together. I was doing virtual yoga for over a year, which I never thought I would do, but it actually was a huge mental health booster for me. So I think just being really creative and making sure that that is a priority, yes, with participants, but also with your own staff. And I think, Mike, your point as far as like the lines being blurred, like that's been something to really, check. I'm obviously still at home, and it's like I wake up in the morning and start work, and then, you realize like it's now been 10 hours and I haven't stopped at the water cooler to talk to somebody. So, just keeping those things in mind, I think it tends to be harder in the virtual setting because you're not doing those things to break up the day. So.
And just to piggyback a little bit off of that, in the focus groups we've done, we've heard a couple of things that I think are food for thought. So coordinators have talked a lot about how their job has fundamentally changed. Like it was one thing, and then overnight, all the duties changed. And so I think that's worth continuing to process and examine what the impact of that is. A lot of coordinators have talked about orienting brand new staff onto the team and having never met them in person. And so we have to evolve some new skills and some new methods for keeping the team a cohesive unit and working through conflict. A lot of issues got worked out very informally in the hallway or over lunch, and it takes a little bit more effort to think through when there's some conflict going on in the team. How do we work through that and discuss that in this different setting that is takes a little bit more effort to do? And I think just as our quitting time is different when we're at home, people have been making an effort to text the participants more and call them more, but some of those boundaries of being available 24/7 to people who are in crisis have really kind of further intruded on our home lives, and thinking through how to rotate that among the teams so that people really have time off away from the phone and away from being on call 24/7, and how to share those duties a little bit more, I think is a critical part of self-care.
Great, thank you very much. Yes. So we also had a question about what do we know? What does the research show? What do we know in practice regarding these services? I presumably mean that means teleservices for juvenile justice. And so, to be honest, I don't know myself. I'm not familiar with that body of research, but I'm wondering if any of the panel members have seen the application of teleservices, and the question may extend broader, sort of the appropriateness for adolescents in general, et cetera.
A lot of the professional surveys that we did come from people either working in family treatment courts or in juvenile drug courts. So I can speak to what the staff in those models had to say. So they definitely felt like virtual models allowed them to work more effectively with the family. So, it's not uncommon to have mom, dad, or extended relative just unable to fully participate either in family therapy or in court because they had work, obstacles or transportation obstacles that may flow down and create obstacles for the youth to attend court. And some of that was removed from virtual hearings. So that was, I think, an exciting plus, was just being able to better engage the natural support system of youth in our systems, because virtual makes it so much easier. There also was this transparency into the youth's home life in a way that's different. You could see the surroundings and see sort of the family context and environment when people were participating virtual. So those, I think, are some pluses. We did not survey juveniles in our participant survey because of IRB issues, so we don't know what they have to say about it, but that's just some anecdotal positives in terms of being virtual with family.
Excellent. Thank you, Tara. I did want to circle back. There was a question, Sheila, perhaps you could provide some clarification around the recording of court hearings. Was it a recommendation of yours that they shouldn't be recorded, or was it just that that's not what's being done in New York?
Yeah, so I can clarify that. I will say that I was referring to, that was an initiative in New York that was put in place pre-COVID. And I know that it's different in every state, as far as some states have been having their court hearings on an open YouTube channel. And obviously the regulations are very different in every state. So I was speaking specifically to New York, where they were not actually being video recorded. The stenographer was recording the session the same way as if they were in person. So I think it just depends on whatever the regulations are in your state. And I know sometimes that varies depending on the type of case that it is. Even if it's criminal court, the problem-solving courts might not be as publicly available. So I think a lot of that just depends on the state regulations. And really just following whatever that would be if they were in person.
Great, thank you very much. There was also a question about what reimbursement models have been effective to sustain some of these programs. Is Medicaid utilized? And I think that depends on the state as usual. Judge Sloan talked a little bit about, Tennessee being a non-Medicaid state, but any input on that?
I think your answer is the right answer. Depends on where you live.
Yeah, I mean, Medicaid is often a very state-specific consideration, and whether or not it's a Medicaid or non-Medicaid state. But you certainly, when you are and it's a Medicaid participating state, it certainly expands the options and the opportunities for reimbursement of these services. And so that's been a big help, and obviously a big barrier for the states where that's not the case. I wanted to raise a couple of additional questions, I think, that speak to the sort of broader perspective here. We talk about how teleservices a technology is widely available, but that's not true everywhere. And I think in many cases, the recognition that it's not available for some has been a barrier to sort of more widespread implementation, not wanting to leave people behind. And I think, Sheila, you addressed this a little bit in your presentation as well. What would we say to practitioners who are thinking about the merits of technology but are hesitant because they know that there are clients in court who can't benefit at that, at this particular moment?
So I think that'll go into a little bit more in the next session, just as far as like when you're doing a needs assessment and seeing what are the technology barriers, and also even potentially surveying all of your current participants that you have now to figure out, do they have a phone but not a smartphone? I think also part of it depends on where you are. I was out in Montana for vacation last week, and I had no Wi-Fi service other than when I was like at the little ranch and there was like 2 bars. So, you want to make sure that it's fair. I know in some places they have, if the individual doesn't have potentially access to technology, but there's a public library right down the street and there's a private confidential room, and setting it up an agreement with the library that on, Tuesdays and Thursdays, individuals are going to come here for set times and be able to have access to that technology. And it might not be in their home, but like it's not 2 hours away. So really just making it equitable. It's a really important thing, because you don't, again, want these people that are already marginalized, that are often in our courts, to be even more marginalized now, where it's like, well, they had a phase advancement, but they still have to come in person because they don't have the phone. And, there have been some creative ways. I think Victor also mentioned it, just as far as like in the last year, especially, there's been federal money, people have tapped into their state budgets. So figuring out what resources are out there to make sure that all the individuals in your court that want to have this access to the technology, whether it's for court appearances, for treatment, and other things like that, that it's available.
If I may, Mike, chime in on this one.
Absolutely.
Sitting at another panel where we were having another a set of discussions similar to this one, we were even thinking that creating some kind of hotspot within the court, even if we continue to virtual services in the long run, having some hotspot or having some station where they'd be able to come in and they'd be able to access the court virtually. So that's also encouraged because we know that at times a lot of the facilities were closed during the pandemic. But as we continue to open up, I think that's something that we can start budgeting for in the future, at least for the next year, is some additional station within the courthouse that is going to allow these participants, it's going to be already ready to go for when they come in, and somebody also providing them technical assistance while they're there.
I love that, Victor. So throughout the country, courts have set up Zoom rooms. Treatment agencies are doing a very similar thing where they're setting up those same opportunities. So I think you're exactly right. Back to your kind of bigger question, Michael. I mean, I think at the end of the day, when in the hierarchy of obstacles to participating in a treatment court, I think transportation is generally kind of, or family obligations or job obstacles kind of are probably the highest. And so what I think we have benefited from in this experience is we get to remove some of those obstacles. So now we are down to kind of more technology oriented issues. And I think the nice thing is, for the most part, I think we can really work on those. In terms of how do you fund that, I think a lot of the emergency stimulus money is supporting some of these creations of Zoom rooms. Also, treatment agencies are doing a lot of extenders, so they're extending their Wi-Fi out to the parking lot so that people can even come to their parking lot, not only to access treatment, but to do other things that they may need to do virtually, including participating in treatment courts. So it's an exciting time, but still, I think we need to be mindful of lack of broadband, particularly in our tribal communities, but in our more rural communities as well.
Great. Thank you. Thank you very much. I wanted to kind of shift focus a little bit to the topic of drug testing, monitoring around that. I know that's a sort of a big question mark when it comes to which services. Number one, what, is it appropriate to do drug testing, remotely? I mean, when you have to, but when you have the choice, what should go forward? And I think there's been a lot of concern among, certain practitioners that they're missing out on use. If someone were in person, they could more easily detect it. They could get the test done more routinely. But we've also seen some evidence to suggest that when sanctions aren't the focus, and they know that jail isn't going to result, they will actually self-report their use. And then in some instances, testing is not as necessary. So I'd love, for the panel to comment a little bit on that, because I think that's a real concern in some ways around teleservices that we could be really creative about.
So I was also a former probation officer, and so I can't think of any community supervision officer that doesn't really spend a lot of time thinking about the integrity of drug testing and the exceptions to the people who want to manipulate the experience. And yes, those exist. I think we have to acknowledge that. But I think kind of your broader statement is truer for the bulk of participants, which is that they were self-reporting their challenges, their relapses at the same rate that it was being identified or by the staff. So when we asked staff what % of the participants do you believe relapsed, and then we asked participants what they relapsed, they kind of reported the same thing, around 30%. So I think that some of the backing off of the jails, some of the backing off of the sort of hyper supervision lens and kind of treating it a little bit more holistically it did end up people self-reported. It's so interesting that they felt so positive about their supervision officer and that they could be open and honest with them. And I can't help but wonder, although I don't know, if it is in part because some of that dynamic shifted to talking more about relapse as sort of a treatment issue and less as something to be punished. I don't know, but there's something that shifted in this, and I think it's worth us continuing to examine it. And I think in the end, the bulk are going to self-report, that for the most part, the integrity can be upheld when you're watching somebody over video. There will be exceptions. I think for the most part, the behavior will tell you over time, you'll know something isn't as it seems. And then I think supervision can do what they're very good at, which is figuring that out. But I think figuring out how to run a program for the majority and then dealing with the outliers in different ways versus setting up something for the exceptions is, I think, perhaps the pathway forward. I don't know, Sheila, if you have kind of a different reaction to that or a similar thinking on your.
Yeah, very, very similar thinking. I mean, I have very strong views, which I won't express here, about not using jail as a sanction at all. I think that was one of the really important, crucial pieces to see the amount, and we heard this across the country, not for everybody, but people that were sharing. And when you're looking at treatment courts and you're looking at that Therapeutic Alliance and all of these things that we know are the best practices, you want somebody to feel comfortable to say, this is how I relapsed, and let's talk through this, and let's figure out, therapeutic adjustments, what needs to be done differently. And exactly to your point, if somebody is actively using, their behavior is going to change. You're going to be able to see these things. And if you actually have, more of a rapport, whether that's with the case manager, whether that's treatment, whether that's judge, hopefully a combination of all of that, that's going to come out. And I think ultimately when you're looking at, the better for the community, the better for this individual, yes, I understand the importance of drug testing, but I just wish sometimes that the focus would be more on some of these other pieces, which we were able to see in this last year because, the other things weren't in place. So I think that is really a hopefully good, positive takeaway that some of those things really stay as robust as they have been.
Great, thank you. Victor, I'd love to hear your perspective from the board on this.
And moving forward from this, I think that we're both on the public sector and on the private sector, we're going to have to go back and really evaluate how we can move forward with smarter testing. What is it that we can revamp? What is it that really worked and what didn't? At least in our with our court, our biggest with our participants is alcohol. Of course, we're a DWI court. So we're able to measure it at a level where a lot of them that were still fortunate to have jobs, that have the funds to be able to pay for this mobile device rather than the interlock device on their vehicle. This mobile device that works pretty much like the cell phone. You carry it around with you. It rings at random times of the day, and then you have to submit a breathalyzer test. It really worked, and we were able to work with the private sector as well to kind of provide some kind of coupon, some kind of incentive for them, that they were going to be on this mobile device for some period of time. So maybe they'd be able to provide a month for free. That gave them time to kind of get funds together. It works off cell phone reception. So anywhere that their phone had access to the cell phone, they were able to utilize this mobile device. So we were able to conduct smart testing whether they were at work or at home. And now here in South Texas, there's a lot of jobs that are out in the rural community, such as some of the male defendants that we had working at the oil fields or through the oil and gas production. They were out there in rural parts of the county, and we were still able to get live tests. So that was really that was really effective, and we were able to order some of our participants to really be on this mobile device, the ones that we really felt were on the edge. So it really worked out.
Great, thank you, Victor. And you also had mentioned in your presentation that there was a reduced reliance on jail sanctions. So maybe perhaps you could speak a little bit about, in instances of positive tests, how did the court kind of rethink their approach?
Correct. And ultimately, at least for us, is that the jail sanction is a very, very last one, very, very that we least want to ever utilize. But what COVID really did was that we stopped sending jail sanctions. And I know that one of the questions said, how were we able to monitor the home monitoring house arrest? So that's what we did. Of course, for some period of time down here in our city, in our county, there was a curfew in place, and there was also a stay-at-home order. So the way we were also pushing for this to ensuring that our participants, we know whether they worked or if they were unemployed or anything like that. What really helped was the monitoring of the home arrests, whether we sometimes did it for 3 days, 1 day, 5 days, depending on the severity of their sanction. So the way we would use it was simple. It was Zoom, and us through the court staff would coordinate to see, well, yeah, the case manager is going to review the house arrest on this day, and the probation officer is going to be in charge of this day, and you know, you can come up with a schedule as your. We were home as well, so I mean, it's not like we had anything else more important to do, rather than, you know, check in on someone at 9 p.m. and just a brief video conference call. Okay, can you 360 your room? How's it going? What are you up to? Well, you know, have some kind of conversation. And it was just a smarter way of doing it, rather than having to send them to jail, because for some time the jail was actually a hotspot. Now, we didn't want for our participants to take in the virus or to go in without having it and come out getting it. You know, that was always our biggest concern, was our public health and our safety. But just getting smarter with those ideas. It didn't cost us any more, other than our Zoom Zoom license that we already had in place. It was a shared meeting with our participant, so we would just basically at times, random times, we'd schedule them and said, hey, you know, 30 minutes before or 15 minutes before, we'd send them a text that said, hey, you know what, please, you know, log in. Here's the Zoom login information. So that's how it really was planned out, and it was very effective.
Thank you, Victor. We have time for one more question, and fortunately, there's one more question in the log, so we can say we got to everyone. What about, you know, addressing sort of the elderly population in terms of their comfort level around technology? I know, Tara, in your survey results, you had the age of participant response. You did mention you had no age differences, but I think there's certainly a, you know, we all think about ourselves and where are we in this technology revolution? Like, I just missed it. I'm a little bit older than that, but at the same time, I wasn't old enough to be like, I'm not dealing with this. I had to kind of get on board and figure things out if I ever wanted to relate to my kids or whatever else. So I'm wondering, you know, amongst the panel, you know, in terms of navigating this with more elderly populations, this may come back to the notion that it may not be their preference to do services this way, and we have to be able to respect that. But any input on sort of lessons learned around this population?
So I'm hesitant to attribute the reason why, but I think there are three populations that I've heard repeatedly when we've done focus groups that have, when given the choice, showed up in person versus virtual. So older individuals, veterans in veterans treatment courts, and individuals in a mental health court. Now, as to why, and whether it's about the technology, whether it's about a sense of social support that's offered in person, a relationship that is meaningful in person, I think we don't know why. But definitely for judges that have sort of offered that dual option, those three populations have definitely risen to the top as to who is likely to show up in person versus on video. I will also say courts have done a phenomenal job of tutoring everyone in how to use this technology and doing practice sessions and really spending a lot of time in orientation, actually like doing exactly what we're doing as a trial run before they have to do it in front of their peers. All of those things can be incredibly helpful.
You're on,
Yeah, and
which is something that really we had to re-emphasize, emphasize. I think when it comes to that, Mike, if I can just add briefly, that also having just a telephone number rather than always encouraging the video conferencing section, providing a telephone number where they can just call in, and we're able to link them into either the Zoom conference or to the WebEx conference, but having accessible for them and making it easy for them just to dial a number without having to press, enter the access code or wait or anything like that. Just make them feel a little bit more secure. The older individuals, of course, that are not as technologically savvy feel that, well, even if I'm not allowed in the court, I'm going to make my way out there because I just want to make sure that I am seen there, I'm heard. So not only did we see it in our TWI court. We also saw it in our criminal court proceedings with county court. It was just that, hey, my attorney's not answering, but I'm here and I'm in court. Well, it's virtual. I'm going to mark you present, but you need to go back home and go log on. So I think just making it easier for them, but just simply even just providing a phone number where they can call in.
Yes, I think in summary, part of it would be that we certainly can offer guidance on how to use technology. Some may be open to that. We can make it easier in the way Victor has pointed out. And then ultimately, we can respect personal choice in terms of coming in service. I know, for me, I remember my board president for years would always want to come into the office and meet with me, and I didn't understand why. He was about 83 years old, and I would say, why do you want to see me? We can just do this over the phone. Why would you why would you drive an hour and a half from Westchester to New York City just to see me when we could talk on the phone? And he felt very strongly it was important to be in person and face to face. And so I think that's going to be the case for some people. I want to respect the time. It's 3:01. We've went a minute over, so I will remind everyone that June 30th is the second session. We're going to talk a lot more about challenges and considerations for preparing for teleservices, both in terms of client and program readiness, as well as some of the preparation recommendations, training needs, and other things that could better situate us for more permanent adoption of these services. So I hope folks will come back for the second session. I appreciate everyone attending today. That concludes our session. Thank you to all the presenters.